30-year-old Mr. Duncan came with a headache. Assess the patient and discuss the diagnosis and management with the examiner. Firstly, greet the examiner. Next, introduce yourself to the patient. The patient is lying down with his hands over his eyes. Hello, Mr. Duncan. I'm Dr. Jane and I'm here to examine you. I understand you are holding your eyes. Is the light too bright for you?
Yes, doctor.
Would you like me to dim the light for you?
Yes, thank you.
Tell the examiner I would like to dim the lights for him. If the patient is muttering words in a confused manner, you can skip the history and tell the examiner that you would like to do the GCS. Say, hello, Mr. Duncan. Could you open your eyes, please? He doesn't open. You pinched his nail bed in order to inflict pain. But don't do it in a way to actually inflict pain. Explain to the examiner in a real case scenario, I would inflict pain on his nail bed to see whether he could open his eyes. And he does open his eyes in response to pain. That would make him an E2. Next, you would check for verbal response. Ask, where are you now, Mr. Duncan? You don't get any response. Then you inflict pain on the nail bed. And if he makes these incomprehensible sounds, it is a V2. Next, you check the motor response. As he's not obeying commands, inflict pain on the right fingernail bed and see if he's flexing or he's localizing to pain. Now, in this case, the patient pushes your hand away. That would make it a localization of pain, which would be M5. So the GCS in this case would be E2, V2, M5, which is 9/15. After the GCS assessment, we need to check for neck stiffness. So we flex the head in order to touch the chest. At this point, we check for Brodzinski's sign as well, in which the knees flex on flexing the head to touch the chest. We then do a Koenig's sign. We flex one leg at the hip and at the knee, and then extend the knee while fixing the hip, and you would find a resistance at the hamstrings. Next, if the patient is able to comprehend what you are saying, you need to ask his permission to undress him fully in the presence of a chaperone. If not, we simply explain to the examiner that we need to expose him fully in order to look for rashes. And we look for rashes everywhere. We might find something that is drawn on this particular patient. We then cover the patient, thank him and thank the examiner. We explain the diagnosis to the examiner. We say, I think this patient has meningitis due to his history of headache and photophobia, his low GCS, and a positive Koenig's sign, or whatever sign comes positive in the patient. He also has a rash, which means that he could be having a meningococcal meningitis. The tests that I would do would be a CT head first in order to rule out a mass lesion so that I could safely proceed in order to do a lumbar puncture. I would send the CSF for protein and for gram staining and cell counts. I would also send it for culture, and if the patient has a long-standing history, I would also send a TB PCR and fungal stain. I would also send complete blood count, CRP, procalcitonin, blood culture, creatinine and electrolyte levels. I would empirically start a treatment of ceftriaxone with vancomycin in the setting of possible meningococcal meningitis. We isolate the patient in the ward because this is highly infectious. We have to inform infection control, and we trace the contacts and give them prophylactic ciprofloxacin.